Again, it's a privilege to be here. I work in upstate New York, in Westchester County, in the Hudson Valley. And a lot of things that we heard today from several of our esteemed colleagues up on the podium in the previous session seem to be focused in and around New York City. And we are in a unique situation. We live in and work in upstate New York, and we take care of patients in upstate New York. And somehow a lot of these funding streams and resources don't seem to be available to us. So we very often make things along as we go. Many people think of upstate New York as this thing up there. You know, you just get past the bridge and you're somewhere up there. The Hudson Valley region, which is where I work, it's growing. The current population as of 2014 is about 2.2 million, with 30% of them being children. And if you just do the math, with even a 9 to 10% asthma prevalence, there's a whole bunch of asthma children out there. Two of the fastest growing counties of the 63 counties in New York State are actually Rockland County and Westchester County, which is where we live and work. So it is not an inconsiderable spec. And the technical problems are now resolved. So I wanted to start with an intro, just to bring out that very often for us, we have to think of innovations and other means by which we can introduce optimal care to our patients above and beyond that of just a clinician. We are a large pediatric pulmonary practice in the Hudson Valley, and as pediatric pulmonologists, we see a lot of bad asthma, and very often our practice is biased in the sense that we are not really seeing the run-of-the-mill mild asthmatics out there, but we are really seeing the worst ones. They get referred to us. And it's, as most of you in the audience know, it's not just about writing prescriptions and telling them, go get better. You know, there's a lot of things that go on beyond a physician's level, which impacts on asthma care, and which is where we have been trying to make some progress in getting interventions. And today what I'm going to talk about, as Amisha had mentioned earlier, we're talking about providers and asthma in-home interventions across the country. Two of my panelists have done absolutely amazing work, and I won't steal their thunder and say what they're going to present. I'm going to talk about something which is a little different and a little unusual in the sense that we're talking about an in-home intervention plan which is funded by a private payer as opposed to health services, the HUD, the state, and so on. And it's just a pilot that we started, and the hope and the reason I'm presenting this today is to hopefully encourage other clinicians and other organizations in the audience as to see whether this is a potential source to bring together the braid that Amisha talked about of different sustainable funding streams so that we can get a composite picture and try to advance care for children. I also work at the Children's Environmental Health Center, and that ties in with several of the aspects that were discussed earlier about in-home risks. So with that small introduction, so the rationale for our little project is that clinicians are often unable to spend adequate time in asthma education and reinforcement within the limited time that we have in our patient interactions. And parents tend to learn best, not in the kind of little bit overwhelming situation when they come in and see a clinician, but rather in a one-on-one, especially in their home environment. And we all know this, that parents often tend to underestimate the environmental risk factors. And one other thing that most of us who have worked with motivational interviewing and reinforcement are aware that sequential teaching and sequential assessment often reinforces learning behavior. So this is a pilot project that we have collaborated with Blue Cross Blue Shield of New York. It's a one-year pilot of in-home intervention, and as opposed to using community health workers, we actually have our respiratory therapist, who is also a certified asthma educator, who goes into the homes to do this intervention. We have a formal assessment for environmental risk factors within the home using the Healthy Homes Asthma Checklist. We do asthma education, including reinforcement of inhaler technique and so on. And then we estimate asthma control. Outcomes are extremely important. We're looking at clinical outcomes while our partner is going to be looking at cost outcomes. The target is about 100 children over a 1-year period, and we are going to assess ER utilization, asthma-related hospitalizations, compliance to medications, and decreased school absenteeism. The visits will be conducted over a 3 to 4 month period for each patient. There will be 2 in-home visits and 2 phone calls, and this is a schematic out there, and if all goes well and if everything is smooth, each patient will have interaction over a 3-month or a 12-week period. And the measures that we're looking at, we'll be looking at self-management goals, looking at a standardized asthma action plan based on age, looking at their asthma history and any episodes of poor asthma control. We'll be looking at standardized measures for asthma control based on age. We'll be looking at the homes and their environmental risk factors, and eventually a program satisfaction survey. There'll be a small incentive to each participant in the plan so that they will let us get into their homes. This is a visit schematic, what we'll be doing at both in-home and phone visits. I'm not going to go over this in detail. The pilot was initiated in late April, and as of mid-November, these are the numbers that we have been able to target so far. 18 patients have actually completed the program, and overall we have reached out to about 180 patients. And the data on cost-benefit analysis is being done right now, so I don't have the data to present to you at this point. The unique aspects of this program is that it's a private payer partnership. There is a trained asthma educator who is doing these in-home visits. We reinforce self-management goals at each encounter. We do in-home assessment, and we track asthma control. Our future goal is to expand this pilot to more patients and hopefully be able to present data on cost-benefit analysis. With that, I'm going to stop and go on to the next 2 speakers who will be talking to us about a much more broader aspect of how they've impacted asthma control. And as Amisha had mentioned, we're going to start from a micro to really a macro level. Thank you. Thank you. Thank you. Thank you.